USMLE style question on dermatomyositis. A 50-year-old woman presents with progressive muscle weakness over the past 3 months. She has difficulty climbing stairs and raising her arms to brush her hair. She also reports a rash on her hands and face and mild muscle pain. Physical examination reveals symmetric proximal muscle weakness, shoulders and hips, violaceous periorbital rash, scaly erythematous plaques over the metacarpophalangeal joints, red erythematous rash on the upper chest and shoulders. Laboratory findings: creatine kinase CK 6000U elevated, aldolase elevated, ANA positive, anti-MI2 antibodies positive, anti-Jo1 antibodies negative. Electromyography shows myopathic changes with fibrillations. A muscle biopsy reveals perifascicular atrophy and paramysial inflammation with CD4 plus T-cell infiltrates. Which of the following is the most likely diagnosis? A. Polymyositis, B. Dermatomyositis, C. Systemic lupus erythematosus SLE, D. Myasthenia gravis. E. Inclusion body myositis. Correct answer: dermatomyositis. Explanation: dermatomyositis DM is an idiopathic inflammatory myopathy with proximal muscle weakness and characteristic skin findings. Autoimmune-mediated microangiopathy leads to perifascicular atrophy and paramysial inflammation, distinct from polymyositis. Key clinical features: proximal muscle weakness, difficulty climbing stairs, lifting arms, heliotrope rash, violaceous rash on eyelids, Gottron papules, scaly plaques over MCP pip joints, Schall-Viesine rash, erythematous rash on chest shoulders, perifascicular atrophy on muscle biopsy, positive anti-ME2 or anti-Jo1 antibodies. Why not the other options? A. Polymyositis, no skin involvement. Biopsy would show CD8 plus T-cell endomysial inflammation instead of CD4 plus paramysial inflammation. C. Systemic lupus erythematosus, SLE, can cause malarash and arthritis, but does not cause muscle weakness or elevated CK. Myasthenia gravis causes fatigable weakness without muscle inflammation or rash. Reflexes and CK levels are normal. E. Inclusion body myositis affects older adults, involves distal muscle weakness, and has rimmed vacuoles on biopsy. Key features of dermatomyositis: proximal muscle weakness, elevated CK and aldolase, heliotrope rash, Gottron papules, Schall sign 2 or anti-Jo1 positivity, perifascicular atrophy, paramysial CD4 plus inflammation on biopsy. Management: high-dose glucocorticoids, plus immunosuppressants, methotrexate, azathioprine. Screen for underlying malignancy, increased risk with DM.